This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to our podcast on cardiogenic shock. With me today, we have our co-host, Dr. Mustafa Ahmed, Director of the Interventional and Structural Program at the University of Alabama in Birmingham. And our guest today, again, Dr. Jason Guichard, who is an advanced heart failure specialist with Prisma Health in South Carolina. Gentlemen, thank you very much, and taking the time and talking about such an important project. The cardiogenic shock is such a large topic. Jason, would you mind maybe defining for us what is cardiogenic shock?
Yes, cardiogenic shock is, you said, is a very big topic. And shockingly, no pun intended, the definition of cardiogenic shock really up to about 2019 was fairly loose. And it took some clinical expert consensus document by Sky that was published in May of 2019 to begin to really kind of detail cardiogenic shock and begin to characterize it a little bit better. Because really up to that point, a lot of studies with cardiogenic shock have been, neutral or negative. Lots of hand waving, lots of arguments back and forth about, these patients were too sick, these patients weren't sick enough, et cetera, et cetera. But they all fell under the definition of cardiogenic shock. So trying to kind of risk stratify and kind of, give kind of shades of gray between, people that have the potential for shock all the way to people who are actively dying. So the Sky clinical expert consensus statement classifying cardiogenic shock kind of did that. So since May of 2019, we've been able to kind of better characterize people in shock. And they put people into 5 different categories, different stages is what they call them: stage A, B, C, D, and E. So stage A is just at-risk patients. Stage B is kind of the beginning stages of cardiogenic shock. Stage C is your classic cardiogenic shock. Stage D is deteriorating or doom, as they like to call it. And then E stands for extremis. So these were people who are pulseless, actively getting resuscitation. So what we could talk about, I guess, just, kind of the true definition of cardiogenic shock would be your, stage C or classic cardiogenic shock. So these are patients that manifest with hypoperfusion that require an intervention. Usually that's an inotrope or a vasopressor or mechanical support, even including ECMO, beyond the volume resuscitation to kind of restore perfusion. Typically, these patients present with relative hypotension. So a little bit about their hemodynamics, kind of drilling in a little bit, and we can also talk about some of their biochemical markers. So traditionally, it's a systolic blood pressure less than 90, or a MAP or a mean arterial pressure less than 60, or greater than 30 millimeter mercury drop from their baseline blood pressure. There's also another kind of caveat to that. And drugs or devices used to maintain their blood pressure above those targets. So some hemodynamic targets, usually the cardiac index is less than 2.2. So this is your cardiac output divided by your body surface area. A wedge pressure greater than 15, normal is between 8 and 12. Right atrial pressure to pulmonary capillary wedge pressure greater than 0.8. So these are measures of RV dysfunction or cardiogenic shock due to right ventricular failure. A PAPI score, which is a score that's generally used to measure RV function as well, less than 1.85. And then a cardiac power output, which is another calculated measure, looking at MAP times cardiac output divided by a constant, which is 451 of less than 0.6. So those are all hemodynamic measures or markers of cardiogenic shock. So biochemically, what does it look like? Usually an elevated lactate greater than 2, creatinine doubling or greater than 50% drop in someone's glomerular filtration rate or GFR, increased LFTs or increased liver function tests. So measures of renal function, liver function, all deteriorating, as well as an elevated BNP, which is a marker of cardiac stretch. So all of these things kind of lump someone into the kind of the classic stage C cardiogenic shock. And these are the patients where something needs to be done to improve their hemodynamics and get them better supported with the various things that we have available to us.
So Jason, just to put that into a less technical perspective initially, because let's say I have a patient come in and having a heart attack, right? So let's talk about some daily scenarios. And if you can help put these scenarios, if you can just help paint the picture of what would put someone into each of these categories. So say someone's come in, let's just say a 45-year-old woman with a heart attack. And the heart attack started a few hours ago, and we take them to the heart catheterization laboratory, take some pictures, see where the heart attack is, and put a stent in, right? Let's just say the LAD, the major artery, was blocked. So as a lot of what this today's topic has to do with is, fixing that heart attack is just a small portion of what needs to be done to get this patient through, correct? And so the patient is on the table, we've just fixed or thinking about fixing this with a stent. In some cases, the patient's just lying there, no shortness of breath. They're just kind of like, I've got this chest pain. The heart rate and the blood pressure look fine. And we send some basic blood tests up, but we fix the artery and they can even go home the next day, right? But what we do know that heart attacks have a high mortality rate. So a lot of them die either before coming into hospital or after coming into hospital. And heart attacks are probably one of the main causes of cardiogenic shock. So can you tell us a little bit about what that patient we just talked about would look like on the table? When you get the call from the cath lab to say, hey, I think this patient's in shock, can you come and help out? How are we categorizing all these? Put that into, paint that picture with the kind of technical specificities you just gave us.
Yeah, so it's a great question. And, as kind of stated before, there's lots of shades of gray with cardiogenic shock. A lot of it is dependent on the patient, kind of the procedure being done and how they presented. So kind of your typical, kind of heart attack patient that gets a stent, these patients really could go either way. Back in the days before we were quick and had lots of ways to attack heart blockages, these patients were very tenuous. But nowadays you can have patients that have a major heart attack get a stent right away and almost are able to go home the next day. And then of course you have the other side of that coin where someone comes in even for maybe something fairly simple, but it turns out not being simple, or there's a delay and the patient's heart gets weak, their blood pressure gets low, and this requires us to do interventions to save this patient's life. So in the scenario that you're describing, someone that comes in with a heart attack in a major vessel that gets a stent, there's a moment, a few minutes to several minutes where there's a little bit of a waiting period to see which direction this patient may go. And this is where the stages of the SCI consensus document becomes helpful, all the way from stage A, at risk, to B, to the beginning stage of cardiogenic shock, to actually having cardiogenic shock, and then worsening there. So it sounds like the patient that you're describing, had the stent, already based on having the heart attack, the patient's at risk, right? They're already at risk. So now the question is, are they going to continue to further deteriorate, or are they going to remain steady with that stent that was just placed? So if someone is having a normal blood pressure and is able to mentate and have a normal conversation with the cath lab operator or the staff, then these patients are at risk, but probably were saved early enough with the stent and probably will most likely stay there. Generally, what we like to do is, watch patients for a little while in the cath lab to make sure that their hemodynamics stay stable, make sure that their blood pressure remains okay, make sure that they, are mentating okay, not having any more chest pain before they leave the cath lab. It's always best to assess someone's shock stage in the cath lab, because if anything needs to be done, it can be done immediately. Once someone gets out of the cath lab and into one of the hospital floors, sometimes the kind of the inertia or momentum to get someone back into the cath lab can be, kind of tricky sometimes. So it's always best to identify what stage someone is in, in the cath lab, make sure that you support them fully, whether or not that's no support or a little bit of support or a lot of support before you have them leave the cath lab.
Well, let me take it even a step maybe before that. Obviously you have a situation, and here we're talking about myocardial infarction, where you have a large amount of muscle at jeopardy, usually greater than 40%. And you have this problem with the heart for the patient's sake. The heart is having problem, pumping the blood, and you have a decrease in the cardiac output and decrease in the perfusion of the organs like the brain, and so forth. So from the patient's perspective, you mentioned a little bit about disorientation, decreased mentation. How's this kind of low blood pressure, less than 90, how does it manifest itself, and how can the patient or the family recognize, not only is having chest pain, but something is not right? They're going into a shock.
Yes, good question. Low blood pressure kind of has some very typical, feelings or findings. I think most people have probably experienced that before when they've been dehydrated or been very weak because they've had the flu or some other illness. Generally, it's, you just kind of feel terrible. That's kind of a general word, just feeling bad. It can be a kind of a general overall not good feeling. Kind of weak and dizzy. Swimmy headed is kind of what is described. When it becomes, pretty severe, it kind of clouds your thinking, kind of becomes difficult to think or carry on a conversation. So all of those are kind of the how the patient feels when their blood pressure is low. What we see as physicians is obviously the actual low blood pressure, the top number, systolic blood pressure being less than 90. Now, what your body feels is obviously a lack of blood flow to the organs. So that would manifest itself, in the blood or biochemically with an elevated lactic acid. So these are all things that we look for with typical blood work when a patient is either in the cath lab or even in the hospital themselves. We talked a little bit about, kidney function, liver function, the not thinking clearly, as your brain functions. So as the heart begins to weaken, we're not able to support the other organs. Those are the way the organs tell you that they're not working as well. You're not able to think as clear. Kidneys aren't working as well. Your urine output drops. The liver, the liver enzymes begin to increase. Those are all things. Sometimes with your intestines, your appetite decreases, and sometimes you can feel full, that your intestines not getting enough blood, sometimes even abdominal pain. So these are all things that, patients can feel when their, beginning stages are actually in cardiogenic shock itself.
What about on exam, the difference between being cool and being cold or not? How specific is that for shock?
So some of the kind of physio exam, or what we call bedside exam findings, these are actually all very good. And as you might imagine, if someone doesn't feel well, one of the things that you'll see is they don't look well, right? So everyone kind of knows what an unwell patient looks like. They can look panicked sometimes, ashen or mottled or dusky, kind of pale appearing. Sometimes they can be, volume overloaded, so have extra fluid kind of either in their legs or in their, skin. They can have fluid in their lungs, which manifests itself as crackles, is often a word that we describe. They can be cold. Not only the patient feel cold, but their extremities can feel cold, because that's kind of the lack of the blood flow getting to the furthest parts of the body. So the body can feel cold and clammy, kind of as if you were very, very nervous. And then the acute alteration and kind of mental status or thinking, which we've kind of talked about already. And then, of course, decreased urine output. So not being able to go to the bathroom because your kidneys aren't actually making much urine. So those are kind of some of the physio exam findings or bedside exam findings that we see as people begin to transition to a cardiogenic shock.
Great. So let's kind of turn our focus a little bit on this patient coming for a myocardial infarction. So we know that cardiogenic shock, in about 80% of all cardiogenic shock, it's caused by a myocardial infarction or a heart attack. Now, if we kind of look at all the heart attack patients, only about 5 to 10% really will develop cardiogenic shock and will lead to mortality. So let's say, for example, we have a patient who's been having, chest pain, and he's brought into the emergency room. They do an EKG. He's got ST elevation in the anterior leads, but then he arrests. He starts going into VFib. They do CPR, and they start the resuscitating process. They're having problem getting the blood pressure up. It's still below 90. They bring the patient back with a sinus rhythm, but the pressure is still very low. This has been going on now for about an hour. Mustafa, they call you in the cath lab, and the ER physician tells you he's got this patient with an acute anterior myocardial infarction, and he's in shock. I can't get the blood pressure higher even with dopamine or even norepinephrine that he has. So where do you go from there? What is your approach to treat this patient?
So a couple of things there. It's heart attacks themselves present in all different ways. Sometimes you'll have someone that literally walks in and they're like, "Oh, I've got a chest pain." They look great, but you do the heart tracing and you find they're having a heart attack, and you wonder how incredibly well that patient gets through, and it's done quickly and there's no damage or very little damage. And then you get the patient that you're talking about, which comes as an arrest. And so this really demonstrates, and we don't see a lot of these because they don't make it to the hospital because they die at home, they die in their sleep or before they can get a chance to get help. And so let's say that patient comes in. The first thing that comes to my mind is what happened? What's the most important thing in that setting? So shock in that setting is immediate, right? The second that patient has that event at home, CPR, right? CPR is the single most important thing someone can do for that patient, because from the minute that heart stops pumping or is failing or is just stopped, the whole premise of shock is based on being able to get enough blood to the vital organs that need it, or the organs that need to get that. And so CPR started initially. So one of the first questions I'll ask is, when was that patient found? What happened immediately in terms of the CPR given? What kind of quality was that? And when did they manage to get on the scene? So let's say that goes ahead and happens. They say, well, this person was administered CPR almost immediately. It was good quality chest compressions. We managed to get a pulse back and get to the emergency department. But because the patient wasn't able to breathe because their lungs are probably full of fluid, they went ahead and put a breathing tube in. So the next question I would ask is, is the patient waking up or not? Has the patient got a neurological state? And these things are very, very important as we go ahead and talk about how aggressive to be. Because Jason, you can comment on this in a while, but there may or may not be a role for, just as important as saving the heart is saving the brain. There may or may not be a role for cooling people down, and so let's say a person gets there and they're neurologically intact, so we feel that the brain has been given enough blood to survive the whole insult, and we really want to go all out. The questions we're asking are, how quickly can we get that patient upstairs, or we say to the cath lab, assuming it's upstairs to the emergency department, and so how quickly can we get that patient in there, and how quickly can we institute measures to get that blood pressure normal? And I think that is, and there's a whole field of research around this now, right? But that's probably more important than fixing the immediate heart attack in those settings, because that heart attack's been going on a while. So what are the methods used? And I'll often have a phone call to someone like Jason immediately and say, hey, I've got this patient coming in. The blood pressure is 80 or 90, and we're able to do that only by drugs, basically. I don't think this pressure supporting itself will require maybe a very quick look at the arteries and a quick measurement of pressures. And the next question is, how do we escalate this situation? And so, Jason, I would call someone like yourself and say, okay, do we keep doing meds and try and open the artery? Do we go ahead and put something called a balloon pump in, which again is debatable as to its effectiveness, but should we go ahead and do that just to augment and support the blood pressure? Should we try and put something more heavy-handed in? For example, an impeller device or ECMO or things like that. And I'm sure, Jason, as you'll say, diagnosis and doing an echo immediately, things like that are important, because is this the right side of the heart failing? Is this the left side of the heart failing? And having these conversations and having them at a high level is very important, because what worries us, and you see this a lot, is it's the right side of the heart failing, but people are going to put in left-sided support devices, or it's the right side of the left side of the heart failing, and people are kind of just doing a one-size-fits-all. So this is very complex, and I think, Jason, this leads into the shock team, right? The whole thought of a shock team. We've developed one of those shock team that are treating physician, the general cardiologist, emergency department people, the interventional cardiologist, the ECMO specialist, the heart transplant or cardiac failure surgeons that would help do that. There's literally about 10 or 15 things you could do at that one time. And this conversation is going to be easier in 5 years' time when hopefully we have a lot of evidence for the different approaches taken. But Jason, why don't you talk us through when you get that phone call, right? So that exact scenario we're just talking about. The blood pressure's low, the patient's kind of coolish, the lactic acid, which is a measure of perfusion of the blood, is a little bit high, the urine output's not great. And I'm like, Jason, should we fix this artery real quick, or should we go ahead and support the blood pressure real quick with XYZ device?
Yeah, those are all great questions. So at our center, I like to try to keep things as simple as possible. And, one way to do that, to better characterize patients and kind of where they are at in the shock spectrum, including what could even be causing the shock, is really a Swan-Ganz catheter. So the, SCI recommendations, were very heavy-handed in their hemodynamic criteria for both defining shock as well as improving it. So Swan-Ganz catheter, which is a little kind of pressure wire that's placed either through the one of the veins in the patient's neck or in their leg, generally during one of these procedures, that feeds a wire through the various chambers of the heart that actually allows us to measure the performance of the various chambers as well as how much blood the heart is pumping. So we get an objective measure of how well the left side of the heart is working, how well the right side of the heart is working, whether there are pulmonary pressures. And all of these pressures and the combination thereof will give us a better characterization of how well or not well the heart is doing. So we have various metrics that we like to keep patients at, goals, if you will. And based on where the patient is at and based on where we want them to be, that dictates largely in our center about what needs to be done, whether or not you can get away with just a simple vasopressor on your inotrope, or whether you need a balloon pump, or the family of Impellas that are available, or all the way to via ECMO, based on the degree of shock. So generally speaking, we like to see a cardiac index greater than 2.2. We like to see, a wedge, less than 15, cardiac power output, which is a very strong prognostic marker of support. We like to see that greater than 0.6. So in the cath lab, if we're not able to get that, as well as a normal lactic acid. So in the cath lab, if we are unable to achieve those metrics, then we will continue to escalate. So if they do not respond to vasopressors or inotropes, then we will escalate to a balloon pump. If we feel like that would be enough support for a patient. If that's not enough, then we'll consider the Impella CP, which is about 3.5 liters of support. If that's not enough, then we go to the Impella 5 or 5.5. If the patient's crashing, burning, and we don't have a full handle on what's going on, or we need even more support, then even via ECMO. So having the full kind of suite and tools available to you and being able to be nimble enough to understand, which device could be used in which situation is always important. Because at the end of the day, what you really want is to restore the patient's normal hemodynamics, to restore the patient's perfusion, meaning getting the lactic acid down, as well as improving end organ function. And really in the SCI consensus document kind of preaches this, as well as some of the other kind of shock centers in the country, Detroit being one, and Tufts as well, that the patient really shouldn't leave the cath lab or really shouldn't be finished with any sort of intervention until they are hemodynamically where you want them to be. Now, not all patients are going to be that way. There are some clinical decisions, with each individual patient about what would be appropriate or not, based on the patient's age, based on the patient's underlying health issues, based on the patient's presenting laboratory values as well as lactic acid. Sometimes those will dictate whether or not we actually do certain support devices or not. But once again, underscoring what Dr. Ahmed was saying, how the shock team approach, having multiple brains, multiple eyes, looking at a patient, looking at the labs, digesting everything in context, both the patient, the insult, and the intervention done, and using that information to kind of guide decision-making and prognosis is all critically important in getting a positive outcome for a patient.
Now, guys, I'm going to stop you a little bit. I mean, you've all mentioned this mechanical circulatory support, system. So we've talked about intra-aortic balloon pump. We've talked about Impella. We've talked about even ECMO. So if you don't mind, can you break it down a little bit, Mustafa and Jason, and say, what is a balloon pump? How do you do this? You're in the cath lab. What's the procedure like, and how does it actually work? And Impella, what is it, and how do you put that in? How does it work? And then maybe we could finish by the VA ECMO that you described.
We'll just go through each one, and then Jason, we'll just kind of talk about this together. So the balloon pump's probably the most simple to place. It's been around the longest, and let's talk about in each case what the gold standard or what the evidence is. I think that's very important to do at this time. So, and it's really easy to do because the evidence for all of these things really needs to improve, and that's just one of the most frustrating things about working in this field. Is you'll have someone that's literally at death's door. And we've all been through these procedures where we have done what it takes. Reason, sometimes not within reason, but you do what it takes to try and get appropriately your patient through. But at the same time, we're evidence-based physicians that would like to say, this is what is best based on this study and these outcomes. And a lot of the field of mechanical circulatory support is growing in terms of evidence, lacks the rigor and the outcomes of many of the pharmacologic treatments we have, simply because these trials are really, really hard to do. The patient populations we're talking about are often about to fall off the ledge, and you get torn between what to do at that time, knowing that you want to be able to do the best you can. And I think all of us agree, all of us in this panel, because we talk about this often, agree that we would like to do things with the most evidence possible and to contribute to efforts to enroll patients in trials and really gather the best we can to guide what we're doing going forward. But we're still going to stop and talk about, each one of these devices. So the balloon pump, Jason, I'm going to let you talk about the kind of physiology of it, but from a procedural standpoint, in the lab, it takes about less than a few minutes to put in, assuming someone's got good access. It's typically put in through the leg, the left or the right. And, the nicest way to put that in is under ultrasound guidance. And you put it in the artery, the femoral artery, which is down by the groin region. And it stays in, it can be connected. The whole process from beginning to end can probably take about, 3 to 4 minutes, assuming you've got a team that's really, really, really getting that thing ready in that time. And it can be switched on and augment the blood pressure. And in terms of taking it out, it usually is pulled, and you just hold the pressure on that, usually on the intensive care. So Jay, you want to talk a bit about the effects of the balloon pump?
Yes, so the balloon pump, is we could talk a little bit about the pump mechanism. That's kind of it's pneumatic, and that'll become important when comparing to some of the other devices. So the size, so it is what we call 7 French, sometimes 8 French. Size, so the higher the French size in the medical world means the larger the hole, right? As you might imagine, if you have a larger hole in your body or a larger hole in your artery, that's going to be high risk for complications, whether that be bleeding or limb ischemia or other complications. So generally speaking, smaller the better when it comes to complications. So the intra-aortic balloon pump, or IABP, is of the smallest sizes for these of the mechanical circulatory support devices, and it comes in at 7 to 8 French. So it's percutaneous, meaning it goes in through the skin, like Dr. Ahmed was saying, usually into the descending aorta via the femoral artery. So its support, because it is the smallest, it also has the smallest level of support. So it provides anywhere from 0.5 to 1 liter per minute of cardiac output. But some of the favorable things that it does, it has the lowest level of limb ischemia. It has very little hemolysis, meaning disrupting the blood inside your body. It also reduces what we call afterload, which is something that's very important, especially in heart failure patients. And also reduces your pulmonary capillary wedge pressure, or the pressures in the left side of your heart, which are also, again, important when trying to rest the heart and make the heart better. So those are all kind of the descriptors of the intra-aortic balloon pump.
So next is the impeller family of devices. These are a pump. The impellers, there's the impeller with the ER, which is the one we were talking about during the IMPELLER during the VAD podcast, which we encourage people to listen to, that we did recently. And then there's the impeller device, IMPELLA. And there's one on the left and one on the right side. And they used to give 2.5 liters of cardiac output, and now give 3.5 liters of cardiac output for the standard one. And it can go up to 5 and 5.5. And there's continual progressions of the advances in technology here, usually put in through the leg. Now, this is different than a balloon pump. The size of the hole in the leg needs to be a lot bigger. Remember, a lot of these patients have bad artery disease, peripheral artery disease. They have blockages, and this is really important, because the last thing you want to do is put some kind of support device like an impeller in someone, and their leg blood flow becomes bad, and you can lose your leg as a consequence of that. And so you have to be well versed in supplying blood flow down to the leg and using strategies to kind of improve that. But knowing those things ahead of time is very important. And the reason I say that is because these things are becoming more widespread disseminated. We get a lot of transfers with these things in, but by then, unfortunately, the leg has had multiple complications, which are too late to do anything about. So early team management of those things is important. And like we were saying, if the leg is not good for one of those, there's this place you can do it through the axilla artery up here by the shoulder. And that can be done still percutaneously, so without the need to surgically cut down. And that can be done fast now. We've done many of those in emergent situations, which can save the arteries of the leg, which if they're too small. But that has its own issues as well, with needing to make sure that it can be closed easily, and also needing to have advanced training in how to do that. And then you can get the surgeons to cut down for you, either in the leg or up here by the axilla or subclavian, and put a graft on there. And then you can use the 5.0 or the 5.5. So the impeller devices are basically this. Imagine you could just take your heart and say, okay, we're going to put something in there which just spits blood out of your heart towards your body in the normal fashion. So the normal cardiac output would be, a couple of liters per minute. The impeller basically does that work on the left-hand side. This is for the left impeller. There's also one that can be done on the right through the leg. Jason, you might be able to talk more than me about that. I haven't really used that much. We use something else, which we can talk about a bit later. So the impeller goes in during the procedure. It provides typically nowadays 3.5 to 5.5, depending on what device, liters of flow, which is a lot, and can theoretically maintain perfusion to the body during that time. So to have someone having the blood, their body needs and prevent organ dysfunction potentially. It also potentially allows you the advantages of being able to concentrate on completing either the procedure or the other stabilization things required at that time, because you're not worried about a patient with zero blood pressure. Taking those out, again, ensuring good flow down to the legs is important in those situations. There's a number of strategies to do that. And the way those are taken out needs to be done in a team fashion, either using pre-closure or using the surgical services to try and close those, or in some rare situations, just applying pressure. So, Jason, I'm going to hand over to you to talk about some of the hemodynamic effects of these. And again, all of us are very strongly strong proponents of continuing to gather. By no means should this be a conversation about, oh, let's go and start putting all these in people. It's not like that. It's something used in an acute situation where there's often very little else you can do, but trials are ongoing, which we encourage everyone to enroll in. Or hopefully there's trials upcoming, more of those we encourage people to enroll in, to really look at, hey, we've got these powerhouses of technology, which are incredible, right? But we want to make sure these actually help people. We all have anecdotes of people were helped, but again, anecdotes don't work in treating a population over a long time. So, Jason, I'm going to hand over to you.
Yes, that's very true. So, in the world of temporary mechanical circulatory support, it's very much a data-free zone, kind of the wild, wild west, if you will, which was part of the reason why Sky put out that consensus document about a year ago, so that we can actually start better characterizing cardiogenic shock, so that we can actually start doing effective clinical trials. So that was one of the most important things to kind of come of that consensus document. So hopefully moving forward, a lot of clinical trials, in cardiogenic shock using some of these temporary mechanical circulatory support devices, we can actually start getting some data. So all of these devices are used all across the country. I would say that this becomes very polarizing. Before I kind of get into Impella itself, all these devices are actually quite polarizing from center to center. You have people that believe balloon pumps can save everyone. You have people that believe balloon pumps do nothing, right? So you have complete and total opposite ends of the spectrum. You have people that believe Impella will save people. You have people that believe Impella kills people. So you have complete opposite sides of the spectrum, all very smart people, all from different parts of the country. And then you have people that believe ECMO is the greatest thing in the world, and you have people that believe that ECMO is the most money-wasting, time-consuming, painful process in the entire country. So very polarizing opinions of each of these different devices.
I cannot thank this enough, Jason. I mean, do you not agree with the amount of conversations you'll have in one day will be going from, I can't believe you didn't do this for that patient, to I can't believe we did that. It was never going to work. And so I can't second that enough. You just put that really nicely. I often describe the temporary MCS world or mechanical circulatory support world really as the Wild Wild West. And it's nothing but full of anecdotes and personal experiences. And it really is a data-free zone, which is actually quite sad for two reasons. Number one, these patients are very sick and actually need evidence-based help, which there just really isn't any. And number two, once again, at MyHeart, we're very proud of, we talk about cost. We talk about, money and that sort of thing. All of these devices, except for the balloon pump, are actually all very, very expensive and spend a lot of healthcare dollars. So not only, is figuring out this, helpful for patients, but it's going to be helpful for our health system as well. But with that as the background, we will stay kind of impartial with all these different devices. I'm sure, Dr. Ahmed, Dr. Bouchard, and myself all have our kind of personal feelings and thoughts about what we would use in a given situation. But we can talk about our opinions at the end, but we will give kind of an even-keeled assessment of all the devices. So back to Impella. So their pump mechanism is axial flow. So that is how you describe their pump mechanism. And there are a whole family of Impellas. There's the 2.5, which makes it really easy. The hemodynamic support is actually 2.5 liters of flow. So that's why they named it 2.5. The Impella CP, which is about 3.5 liters. The Impella 5, which is 5 liters. And the Impella 5.5, which is 5.5 liters. So it makes it really easy to determine the level of support. As you might imagine, as you get higher in support, it's a larger device, also more expensive, but it's a larger device. So the cannula size or the hole that it makes in someone's leg or otherwise gets bigger. So as we've talked about before, that increases the chances for complications. So the bigger the size, the more complications. And in addition, that's left-sided support. There is an Impella RP, which helps the right side of the heart. So this is a device that has about 2.5 to 3.5 liters of support for the right ventricle. It's put through the
usually the right femoral vein, and this pumps blood directly from the right side of the heart, so the right atrium, to the pulmonary artery, so bypasses the right ventricle. So all these devices are good. As we've talked about, they all provide different levels of support. So picking the right location of the device, the right size of the device for the right patient is a little bit more of an art than it is a science, as we've talked about already. But remembering, kind of the pros and cons of each of the devices, as well as, identifying which suite of Impella tools would be best for your patients is critically important.
Well, thank you, Jason and Mustafa. Obviously, this is, as Mustafa mentioned, is a very sick patient population. 50% of a patient developing cardiogenic shock will die within the next 6 to 12 months. And some of the problem that we have is of course, the intra-aortic balloon pump, which has been around now for 5 decades, supposed to increase coronary perfusion as well as increase stroke volume and cardiac output in these patients. You have this axial flow device, basically that takes the blood from the left ventricle and pushes it into the aorta with the Impella. That is very, very, powerful mechanism to increase cardiac output. And you don't even need an EKG. I mean, basically you can have a patient in VTAC or a patient that is in asystole, and this device will function, will work, and the patient will completely wide awake and talk to you, while
it is. I will tell you, technically, on that standpoint, I think pretty important. So that is said, but if the left side of the heart is you have the right side is not pumping properly, correct, Jason? So there's going to be issues.
Yes, that's correct. Yeah.
I'm sorry. So we were saying that these are very sick patients, and some of the problems that we have, and Jason, you were mentioning some of the clinical trials, all the shock trials that we've had have shown no difference, compared to one versus another. Now, they have a difference versus medical therapy. I mean, they do improve survival, one or the other, versus medical therapy. But which one is better, the balloon pump or the 25,000 device Impella? There hasn't been any difference. Now, there's this very, very important, trial that is, I think, ongoing, and they've started with the Detroit Cardiogenic Shock Initiative. Now, that would remind you, it was a very, very small number of patients. It was less than 50 patients, but these patients presented, they were very, very sick. I mean, they were doing even CPR, leading to the cath lab. Very, very sick patient. And they've realized that in these small number of patients, if you really establish mechanical support very early on, then treat, the infarct-related artery, their survival was up to 75%. To discharge, which is really, really fantastic, and brings about the notion to, when you have someone in cardiogenic shock, you treat the shock, first, and then address the cause of these patients. So this is an ongoing study. At least, a lot of the patients were mechanically supported, most of them with Impella. But I think this is going to be so worthwhile pursuing this multi-center study. Hopefully when this COVID, pandemic is over, clinical trials will be ongoing. Is this something that is going on at your side, Mustafa or Jason?
Yes. So, a couple of trials there. This CSI, Cardiogenic Shock Initiative. It's a registry, not a trial, but there is some protocolized approach, data collection. And so while it's not going to be the gold standard step forward, it's a step forward, and proponents of that are saying, hey, we've got this, look, mortality used to be, all these people basically used to die, or most of them. Now we've managed to improve it to this. Again, it's not a randomized controlled trial, but it is a registry. It does have protocolization. It does have the kind of definitions required to really get towards improving that in that kind of data. There's another trial which we're, is very interesting, and which we are a part of. It's called the DTU trial. And so this is a trial where when people come in with a large heart attack, the big widowmaker on the front of the heart, front wall of the heart, it's actually saying, okay, before you even go ahead and fix that artery, go ahead and place a device. It's a Abiomed trial, so it's an Impella device, and saying actually unloading, so taking the stress off the wall of the heart is going to be just as important in the long run as fixing that artery because we know that even though we fix many of those all the time, the outcomes are not great. Those patients still end up with large infarctions, large hearts, failing, often needing things like transplant or circulatory support or such in the future. Is this going to be something that can kind of advance that field? So that's something which sounds strange, right? Hey, I'm not going to fix that artery right now. I'm going to put this device in and wait half an hour. But that is a trial with a lot of excitement growing, which are also involved in. And then there's the registries for ECMO, the ELSO registries, which ensure that people having ECMO have the correct data put in, the outcomes tracked and monitored, and allows a more international approach to that. Jason?
Yes, there are lots of ongoing registries which can be helpful with quality improvement and outcomes. And then there's lots of randomized clinical trials coming out in this space, kind of looking at all of these things that we've been talking about. So hopefully in the coming years we'll begin to have actually more evidence about the proper way of taking care of these patients. It'll be very interesting. You've got pros and cons for all these different things. The folks in Detroit have done very well with their patient population, but of course they are a well-oiled machine and they do things very well. So you could almost argue the same thing that you did for the initial stages of cooling or hypothermia protocols, where possibly some of the differences were that it was just a higher level of care. Patients or providers paid more attention when these patients were cooled, and the argument was that they got better intensive care at the time of their arrest. So that was really the reason why they improved with cooling or hypothermia protocols. So it'll always be difficult in the absence of a true randomized clinical trial to assess if a intervention improves things or is causative. So that's why randomized clinical trials such as the DTU trial and others will be very important to kind of guide what's going to be the best way to manage these very sick patients. So we I guess we will just we will see how all these shape out. I would say probably the biggest issue with Impella trials is of course the vascular complications. So whether or not the vascular and bleeding complications will outweigh the benefit that is seen with unloading the ventricle first before PCI, I guess remains to be seen. So lots of exciting stuff, and we'll kind of see how things shape up in the next couple of years or so.
So thank you very much, Mustafa and Jason. This concludes part 1 of our treatment of cardiogenic shock. And we've described 2 techniques to support the circulatory system, that is intra-aortic balloon pump, and that is also the Impella. Next week, we'll be describing ECMO, which is a very powerful and very efficient way of supporting our patient in cardiogenic shock. We'll talk about that coming up.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.